Physiologist Society. We welcome all the distinguished delegates, eminent speakers, friends and colleagues. Friends, as you all know, that this is a one-day conference and the whole day's schedule is tight and jam-packed with the sumptuous academic feast. So I will not take much of time, and before moving ahead, I would like to tell you that this third summit and hands-on workshop on non-surgical nose reshaping and face lip augmentation with the help of neurotoxin and dermal fillers. And we all are aware that this is a very nowadays a hot cake in the field of dermatology, and everyone is interested to know and learn the latest techniques in this particular field. So without wasting any more time, I'll straight away come to the scientific session. We start our scientific session with the basics. Our first topic is the applied practical anatomy, vasculature, and the physiology of nose. We have the learned speaker, Dr. Sukhbir Singh is with us. I invite him to the dais to deliver his talk on the topic allotted to him. Over to Dr. Sukhbir Singh.
Thank you, Chairperson. First of all, I'd like to thank the FADS committee for inviting me for the lecture. I'll be speaking on nasal anatomy, physiology, and vasculature. The main focus will be on the vascular anatomy because nose is not a safe area, first of all. It's always because the vessels are everywhere. Every plane, there are anastomosis, as I'll be showing you in my next slides. If we go on to the aesthetics of the nose initially, let's talk about the aesthetic proportions. Our face can be divided into 1/3. The face can be divided into 1/3. The upper 1/3 is from hairline to the glabella. The middle 1/3 is from the glabella to the subnasal, and the low 1/3 is from the subnasal to the mentor. Also, we can divide it into the 1/5, the rule of 1/5. In the rule of 1/5, the center, the middle 3/5 is occupied by the nose. So that's how important nose is. The nose is the front exposure of the patient we have to be focused on, and that actually is a very important part of the aesthetics. If we talk about the nasal width, that is, I'm talking about the nasal root width or the bony width, it is important to know that if you can, the defining points, if you see, they start from the supratarsal fold. That's the way the radix starts. So the nasal root width has to be lesser than the ala base width. If you see the ala base, it is equal to the intercanthal distance. And if you see the angle of mouth, it has to be 1 to 2 mm shorter from the angle of mouth. So if any part of the ala extends beyond your intercanthal distance, suppose it is beyond this point, so that's called nasal flare. So we have to correct that, mostly surgically, but non-surgically we can reduce by a few methods which we'll be showing in the hands-on session. If we talk about the tip projection, which is one of the most important part of the nasal aesthetics, the tip projection, which is the vertical anterior posterior projection of the tip, it should be 0.67 times that of the length of the nose. Now, length of the nose, we actually start from the radix to the tip defining point and not up to the subnasal when we talk about the length of the nose. Mostly in Asians, when we talk, the radix actually is slightly lower as compared to the Caucasians. The supratarsal fold or the the lash line between the two lash lines is where the radix starts in most of the Asians. And it's very important when we do augmentation of the nose, the dorsum, that we should not over-augment the radix part. If we over-augment it, then it becomes more Caucasian look, which we have to avoid. Let's talk about the ala proportions. Again, ala has to be a typical seagull appearance, that's the ideal ala shape, which we take care during surgical reshaping also, and non-surgical also we try mimicking it as much as possible. If we talk about the ala proportions, a ala can be divided into three parts. So the inter-ala distance, as I was told, it's equal to the intercanthal distance first of all. So if So the ala can be divided into three parts. That's from the tip to the upper point of the lower lateral cartilage is the upper 1/3. Then the middle 1/3 divides the lower lateral cartilage into two parts, and then up to the subnasal. The important point to be followed is the alafacial groove. That's a very, very important point. Suppose the alafacial groove is extending beyond your intercanthal distance, that means there's a nasal flare. So nasal flare is mostly corrected surgically, which is very easy to do. Non-surgically, not so easy, but we can slightly move it inwards through our filler injections, the filler techniques. Coming on to very few angles I'll be defining about. One important angle is the nasofrontal angle. Nasofrontal angle is the angle made between your dorsum and the forehead. So it's approximately 115 to 110 degrees in females. In males, it's usually between 95 to 100 degrees. Again, in Asians, we have to be very, very clear that we should never over-augment this part of the nose. If we over-augment this part of the nose, it becomes more Caucasian and more, especially females, we should be very particular. Otherwise, we give a more manly look to the patient. Secondly, the other important angle which we talk about, which is important for filler point of view, is the nasolabial angle. Again, when we talk about the tip projection, as I explained you, it should be 0.67 times that the length of the nose. That is very important. If we do not maintain that, we'll get a very acute or a too much obtuse nasolabial angle. So it can be an under-projected nose or a tip or an over-projected tip, which is not very aesthetic. So that has to be taken care of. Let's come on to some of the other part of the anatomy of the nose. The main part is the septum, that's the central point. In surgery, in surgical anaplasty, we always say that the nose follows the septum. So always we have to focus on the septum in the surgical point. That's the first step we do surgically. If the septum is deviated, no matter whatever you do in a surgical procedure, the nose will always look crooked. So when we talk about fillers, we try to do the tip defining points and the dorsum in such a way so that we are able to, the light reflection is changed so that the septum doesn't look so crooked if it is there. Other parts of the cartilage I can talk about is the ala cartilage. It has got three parts: the medial crust, the intermediate, and the lateral crust. Now, if the lateral crust is too much, which is usually the case, it can lead to a lot of nasal flaring. Sometimes the medial crust is too much deviated, it's bifid, so that has to be taken care. Surgically, it's very easy to do. Non-surgically, not so easy, but we have to be very, very careful when we inject. We do corrections non-surgically in these cases. Let's talk slightly about the physiology of the nose. The nasal cavity is a hollow cavity, and we have the septum again. Again, we have the septum, which is the centermost point of the nose, or the defining part of the nose is the cartilaginous part, and then the bony part. We have a mucous membrane which warms the air which we breathe in, and then it also clears away the mucus and the small particles which can accumulate. Then we have got the turbinates here. Turbinates basically not only increases your surface area of the nose, but also it helps to moisten the air which we breathe in. So these are the three turbinates of the nose: the superior turbinate, the middle, and the inferior turbinate. Let's go on to the vascular anatomy, which is, I feel, the most important part of a lecture. Okay, don't be afraid of this photo. Actually, this clearly tells us that in nose there is no safe zone. That is why everything is marked in red. It's all the vessels which are crisscrossing everywhere. There are not only anastomosis between each other, but there are reciprocal anastomosis which way up to the ophthalmic artery. And blindness is the worst complication which can occur with any filler injection and the most dreaded complication. And nose is the closest area to the ophthalmic artery, so one has to be very, very careful. Obviously, aspiration has to be done, mandatory, but aspiration is not 100% proof. So be very slow when doing a nasal filler. Never try to inject too much large boluses. That is a very thing. Let's talk about the anatomy in a bit more detail. Basically, the facial artery is a branch of the external carotid artery. It enters the face at the anterior border of masseter. Then it curves around the buccinator muscle, and as it ascends up towards the lip, it gives the superior labial artery. The superior labial artery again gives the alar branches and the tip branches. After giving the superior labial artery, the facial artery continues as the angular artery or the end artery up to the angle of the eye or the medial canthus. So as it is ascending upwards, around the beyond the ala, it also gives light to something the artery called the lateral nasal artery. If you see carefully, the lateral nasal artery is anastomosing with the lateral nasal artery of the opposite side. So there are crisscross anastomosis everywhere. If you see upwards, there is a dorsal nasal artery, which is in first branch of the ophthalmic artery. So dorsal nasal artery, anastomosis again with your angular artery. So we have anastomosis of angular artery with dorsal nasal artery, here the lateral nasal artery, the branches to the tip, the branches to the ala. So there are reciprocal anastomosis everywhere. So even a small embolus, a small tiny drop, it can go right directly into the ophthalmic artery and cause blindness. Also there are anastomosis between the supratrochlear and the supraorbital artery along with the angular artery, which is again a branch of the ophthalmic artery. This is again a clear picture showing the ophthalmic artery with the branches of supraorbital, supratrochlear, the dorsal nasal, all anastomosing with each other with the angular artery. So there's a dense anastomosis everywhere. So no area is a safe zone. Obviously we need to know which is the layer in which the vessels travel. So it's mostly the SMAS layer or substance layer in which the vessels travel. So in nose, either we should be too deep, that means on the supraperiosteum, or it should be very superficial, dermal or the intradermal injections, which should be done. We should not try to go sub-SMAS or SMAS. Sorry, just a few seconds. Just the mucous blood supply and the level of injection, as I told, dorsum and lateral nasal wall, we have to supraperiosteal. All other areas, intradermal or dermal injections. Just to conclude, knowledge of anatomy is the utmost important before contemplating the nasal procedures. Always be cautious regarding vasculature, hence always aspirate. Maintain adequate tip projection. Thank you.
Thank you, Dr.